Hello, my name is Niloufar Mirhaghani. I'm consultant psychiatrist in Barnsley CAMHS. I'm here with me is...
Hello, my name is Stephanie Wallace. I'm team manager for Barnsley CAMHS, and I'll be talking about the new and enhanced spa offer that we have for CAMHS.
Hopefully I do it right. Just to give you a bit of a background about access and waiting time standards. So when the Future in Mind in 2015 was published by NHS England and Department of Health, they set out ambitions to improve mental health services over 5 years by implementing a few strategies, and one of them was to introduce access and waiting time standards. So hence then the NHS England and NICE published the access and waiting time standards for children and young people with an eating disorder. So all the local transformation plan across the country puts the establishing an eating disorder community service based on these standards as their main priority. So did Swift and Barnsley CAMHS. So our service has been commissioned against these standards. So we have got, so the service has been developed over the last 2 years, and we have got a pathway with, that which outline the journey of the young person from where they come to CAMHS, when they receive the referral, to the, and when they get discharged from the service. But we have got, a very busy flowchart that I felt that it would not be really helpful to put like a busy flowchart here. So I take you, step by step as what happens when a child, comes, for instance, to yourselves and refer to our service. So the first thing that may come to mind is what presentation we see in CAMHS. As you might be aware, the ICD-11 is coming out next year, and we really do not really bother about what diagnosis they might get, but as long as they present with a very low weight, not very, but just low weight for height, or a low BMI, significant weight loss, which is more than 15% of the weight over 3 months, or increased fear of the weight gain, they have distorted body perception, and that low weight has affected their social functioning, personal functioning. That would be the main core symptoms of eating disorder. And some of these young persons also might have a binge eating, and they might engage in binge eating. So you have got these, as long as that are the main features that we would look into as the main diagnostic criteria, as the main features of the eating disorder. Obviously, as part of that, we need to make sure that it's not a part of a physical illness, it's not diabetes or IBD or tumors, and you do a physical examination and blood, but that should not delay the referral to CAMHS. So if you have got the basic information and you have arranged for ECG or bloods, just refer them in. So then it comes to the decision whether this is a routine or urgent, and what informs what is the urgent is if there has been a rapid weight loss, as I say, over more 15% of the body weight over 3 months. That's quite significant. The percentage median BMI, I explain to that a bit later, but that's quite important. And severe restriction of dietary and fluid intake, which is about 500 kilocalorie per day. So if you ask them, they say, I had a small bowl of cereal in the morning, a few strawberries, and then fish fingers for tea. That's definitely below below 500. So very, very limited, fluid or dietary. And if they're concerned about, for instance, orthostatic hypertension or bradycardia, again, that may make it a very urgent referral. If family are not able to cope and at the end of their tether, that's again quite important. Excessive exercise, loss of period. Although loss of period is really difficult sometimes because of sometimes young people are on pill or whatever, and is not really in ICD-11 is not a part of the diagnostic criteria anyway. But sometimes if person says I have my periods, but now they have a stop, again that's it's likely that they have the eating disorder has been more than 6 months. And if they are suicidal. So once you have got your information, and then you can either call our single point of access and make a verbal referral, or you can send us a fax or letter. So the main information that we want is height, weight, blood pressure, and pulse. Blood pressure and pulse, ideally, if they will be sitting and standing, that would be really helpful because we can then work out how serious, if there is any serious orthostatic hypertension. Ideally, we would like to have bloods, but what is really important to include calcium, phosphate, and magnesium. And this is the list of the bloods that has been advised by Junior Marzipan that we need to have as a baseline for eating disorder. What has been sometimes been missed, for instance, for the information that we get, is the height. So the focus is on the weight, and sometimes height is forgotten, but then we cannot work out what is the weight for height or median BMI. The other sometimes query has been whether an ECG is needed or not. So a NICE guideline in 2017, which was published for eating disorder, which was published, I think it was in May or March, have got a very extensive list of when an ECG is needed. I only put the main ones, if you like, but as I say, please refer to that to make a decision whether you need to do an ECG. So things like rapid weight loss, bradycardia, hypertension, medication that can prolong QT interval, and electrolyte imbalance, or any history of abnormal heart rhythm. So once you make the referral to the service, and we have got the information, then perhaps one of the main things is the weight for height. But as I say, there are other factors that we make a decision. So if, based on the standards that have been set up by NHS in England, so if this is urgent, routine one, so we see them the ideal is we see them within 15 days to do an assessment and to start a nice concordant treatment within 4 weeks. A nice concordant treatment included self-guided CBT, psychodynamic psychotherapy, CBT, family therapy, and IPT, interpersonal therapy. If it's urgent, then we see them within 1 week and start the treatment within 1 week. And if it's emergency case, is within 24 hours. We this part will triage the case that you refer within 24 hours and get back to you to say it is routine or is it emergency or urgent. And that is the junior marzipan that I was referring. So there are two marzipan guidelines. One is for children and young people that has been published by Royal College of Psychiatrists. So they are different from adults. So if you're referring, please refer to junior marzipan. So that in junior marzipan, what I really like, there is a table that categorizes red risk, amber, and green for physical risk, for instance, for BMI, the median BMI that I was talking to yourselves about, or about for instance, QTC interval, what are considered as a red or amber. There is also we use Excel program work for height. That is quite easy. I can share it with yourselves if you want to, and that's again you just put weight, height, the date of birth, and is a female or male, and they work out your weight. What is the median BMI or weight for height. The other thing that I need to tell you about, there is an app, Junior Marzipan app, that again, that's quite easy. If you download it on your smartphone, it's quite easy to use, and it again shows you how many red category that you have, and then you make a decision of is it an urgent or, a routine. So
the app can really help guide
definitely
how quickly they need seeing and refer.
Yeah, you can. It's what are the risks? I have actually on my phone, and I probably you can't see it, but yeah, it is really helpful to have to download this app. It's quite handy. So then you again once you have got your your blood results or ECG, then if you are worried about if you see any of these heart bradycardia, QTC more than 640 in girls and 400 in boys, history of recurrent syncope, which is very extremely important, or tympanic temperature of below 35.5, any severe biochemical abnormalities, refer to pediatrician, but at the same time refer to CAMS, because then we liaise with them immediately to develop a care plan. What I need to draw your attention is about refeeding syndrome. So refeeding syndrome is a very serious complication of refeeding. It's not very common, but if it happens, it can have really severe consequences for the young person. Is usually it happens because the young person who has starved themselves, now once they start to eat, the body start to secrete insulin and to break down the carbohydrate, and to as part of the Krebs cycle, then we need phosphate, and the young person that already have very low depleted level of the phosphate, then as start to use the phosphate, the level of this phosphate drops significantly, and that can lead to confusion, coma, and heart failure. And usually refeeding syndrome happens within the next few days, maximum to about 2 weeks. So that's why there's a lot of emphasis that please check phosphate as once you order bloods. Again, that's this has been set out as based on the national and access waiting time standards. So if you see a young person and you feel that's they probably are routine, and they need to be seen in 4 weeks' time, they will be seen in 4 weeks' time by CAMS, and we agree with you, then they still need to be monitored weekly for blood pressure, weight, and pulse, and repeat any abnormal bloods until they're seen by us, because I think sometimes they may deteriorate quite quickly in the few weeks that they are waiting to be seen. They may restrict their food intake significantly, or they may exercise more, or for whatever reason they may get really unwell. But sometimes, sorry, I don't know what jumped up, but it might be we may get a referral, for instance, from a school nurse. And then again, we will our SPA contact the family and says, "Have you seen your GP recently?" And if they say no, so they say, then we advise that for an urgent one, please see your GP within 2 days. If it was a routine, see your GP within 14 days. And that's again AWTS stands for Access and Waiting Time Standards. And after the diagnosis, you will get a comprehensive care plan that outlines what we do, and if sometimes families would like to come to GP for monitoring of the weight and blood pressure, pulse, because of the various reasons, closer to home, or because of the stigma of accessing, mental health services. So then we advise you, could you please, monitor the weight or blood pressure. And that's So, and once we diagnose them again, that we, as I said, if his agreement was it to be done by yourself, our preference is actually we do it ourselves in house, to check the weight and the other physicals. But as I say, sometimes families would like to be done at your surgery. And if there was an indication that we need to be done, repeat the blood or ECG, we contact yourselves or put in the care plan for that. And what happens is just a bit of what happens in once they come to camps. So we are working towards doing a MDT assessment. So dietitian, and psychiatrist, and one of the nurses see the patient together. So we see, at the moment, we sometimes do that if it was possible, but generally they will be seen by one of the clinicians, and assessment is done, and then the same day we advise them about what is the diet plan they need to start to go on, and arrange them to see the dietitian if they were not seen the same day. Agree with them what is the frequency of the physical monitoring that we need to do. Sometimes it's twice weekly rather than once a week, and give them self-guided information about how they can support the young person around their meal time. We sometimes involve our crisis team. For instance, if the young person of the family needs further support, so the crisis team go home, or the outreach team go to the person's house and observe what happens at the mealtime. What gets in the way of the family feeding their child, try to advise them, find out what is going wrong, and advise them what can be changed for the young person to eat. So then family therapy or individual therapy also on the offer. Some families do not want family therapy, or the young person do not engage in individual therapy, but there is a lot of evidence, the NICE guideline advise family therapy as the main, if you like, the gold standard intervention for eating disorders. If referral to wards, that's mainly for tier 4 or pediatric wards. If the young person do not make any progress, usually after 4 to 6 weeks, and there is no progress, their compliance with treatment plan is very poor. There are physical risk, concerned about the physical risk, or they're virtually refuse all the food and drink, then we refer them to pediatrician if they are physically compromised, medically unstable. If not, then it would be a mental health unit, tier 4 bed. Support services. So there is South Yorkshire Eating Disorder Association, that there are SAIDA, there are a service that supports young people who are worried about having the eating disorder, or who have had eating disorder in the past, but they have perhaps recovered, but they're now worried about might have a relapse, especially when the stressful time of them, their life. For instance, if they have got A levels, or things like parents separating, so those anxious time that can increase their likelihood to have a relapse. Beat or Beat Eating Disorder, that's a good website. I've got a lot of information, useful information. Anorexiafamily.com, that's set up by a mother of a service user, not in this area, but this person has had an academic background, and her daughter developed anorexia, I think, from very young age, maybe 11 or 12, and now the girl is about 18. So she has done a lot of video, which can be found video links on the YouTube about that, about eating disorder and support for families. She also has got a book. We have Swift had invited her to do a workshop for both professionals and families. So it's something that we approve of if you would like to signpost families too. So I think that is, so my references were, marzipan and NICE guidelines.
Brilliant. Thank you very much. Thank you. Any questions for Dr. Mirhaghani about eating disorders?
Sorry, it's just a query. We don't normally do ECGs in children.
Okay. So sometimes we have sent them to Barnsley Hospital. I'm not sure. When I asked, requested, it was done. So I'm not sure if is it different GP surgeries do differently, or all of you don't do it, because I'm sure that we have requested and it has been done.
As far as I'm aware, I thought generally as GPs it's not something we would normally do. If they're quite adult size, then we might do, but for the younger end, we wouldn't do them or interpret them really.
Okay, so that was good to know.
So it's not just the doing them; it's the interpreting them as well.
Yeah, interpreting them. Yeah, that's right. Yeah, no. So I think I assume that families have gone to Barnsley Hospital then to have it done.
Yeah, I think that's right, really.